Hey guys, Andrei Pop here, System Structural Director for Ascension, Illinois. I have the great pleasure today of interviewing Lynn Hickmann, who is our Valve Clinic Coordinator Extraordinaire. I feel that the Valve Clinic is oftentimes what makes or breaks a successful valve program. And there's nobody better equipped than Lynn to tell us about how it's done. Lynn, thank you for agreeing to this.
Thanks for having me.
So let's kind of start from the beginning. Can you give us an overview of what happens when you get a phone call or a text message from me, or somebody's trying to send us a structural patient? And let's start with emphasis on TAVRs.
Okay. Yes. So typically I will get notified of a referral, um, usually, yeah, via email from the cardiology office or sometimes direct text from some of the physicians. And really all I ask is for a name and date of birth, and then we take it from there. So if it's someone being referred from an outside hospital, um, most of our referring sources know what I need, but I ask them to just fax me their most recent note and reports of their any testing that they've had. Typically, they would have an echo at baseline, of course. And so I just do a quick chart review on the patient and kind of figure out what testing they may still need, make sure that they're an appropriate patient coming through, and then we would line them up for what's next. So the valve clinic appointment, we'll schedule a date for that. And if most of them haven't had a CT scan quite yet, so we typically would do the CT scan on the same day as their valve clinic visit. We have dedicated slots set aside for our TAVR patients. So we try and really limit their visits here, so we get as much done in that one day as we can. Um, so our clinic will reach out to the patient, kind of explain the process, and get them sorted for their initial appointments.
Yeah, and I think that you know, that's honestly the only process that I've known. But I am always surprised going to other places and talking to people that there's a tremendous amount of variability in how patients are processed. In some places, cardiology runs a separate clinic from surgery. Many places require multiple clinic visits, and I think the way that you've organized this, the majority of our patients who have a actionable condition, let's say they have severe aortic stenosis, end up having a single valve clinic visit before their procedure and leave the clinic with a date for the procedure as long as they're willing and there's no complexity to it.
Yeah, it's worked out for us, and we get positive feedback from the patients. You know, a lot of them have trouble with rides or have to ask their kids to take time off work to get them here, and so as much as we can limit that, the trips here, we do try and do that.
Okay. And I think the other thing that is not necessarily super common is this idea of having dedicated CT scanner slots. We run our valve clinic Wednesday and Friday afternoons, and how many spots do we have on Wednesday and Friday morning dedicated to the structural clinic?
So I have two spots on hold, and then there's always a third additional one that's there if needed. So if we need to like wiggle someone in last minute, I do have a third optional slot. So
Yeah, and obviously,
4 to 6 a week. Yeah.
a lot of the patients that I would send from clinic or other people from our practice send will have had their CAT scan done before then. And that's really the only test that we feel we're perhaps better equipped than others are doing. We do rely on outside coronary angios. We do rely on outside echoes if they're good quality. So we try very much not to repeat that testing. Um, Kind of looking at the valve clinic itself, can you kind of outline what happens the day when the patient comes to the valve clinic. They come in the morning for the CAT scan, and where do they go from there?
Yep. So once their CAT scan is done, the staff in that area know the patients that are coming to our clinic. So they get walked over to get checked in to our clinic. Our medical assistant then rooms the patient, and she does their vitals and gives out the KCCQ and any other questionnaires that are needed. And then a nurse goes in and does a med rec and kind of the frailty assessment. So we do the 5 meter walk and all that in that initial visit, like in the first 15 or 20 minutes, get it out of the way. And then we have the interventional cardiologist and the cardiac surgeon are both kind of dedicated. We have at least one surgeon that comes for each valve clinic afternoon. And so the patient within that initial visit will see a cardiologist as well as a surgeon separately. And then I would go in once they're done talking with the docs. I go in and kind of tie together any of the additional tests that might be needed, or we'll schedule them for their procedure date and go over instructions, answer any questions. So
Yeah, and
it can be a long visit, but we get everything done.
yeah, and I think unfortunately we're to blame for the length of the visit a lot of times because most of us are doing this kind of in between cases and running around. And so sometimes, the patient has to wait a little bit between the moment they see the cardiologist, the moment they see the surgeon. But also what's great about the way it's set up is that you know who needs to see whom, right? So if there's somebody with functional MR, for instance, they don't necessarily need to see a surgeon. On the other hand, we've recently implemented a process where for tricuspid patients, we have everybody see advanced heart failure. So we're trying to get everything done in as little time as possible. And I think one thing that the patients like is the fact that they leave the clinic most of the time with a scheduled procedure. And that is really a testament to how well you organize everything. And then the fact that we get to look at a CAT scan for TAVR in real time, we look at echo in real time with surgery if necessary, and most of the time we make decisions in that one visit. The other thing that I think is a little bit perhaps different from the way other people do it is the fact that we see patients sequentially rather than at the same time. So in the vast majority of cases, I will see the patient. The surgeon comes in a few minutes later and sees the patient. So I start with patient one, they start with patient two, and then we switch. We've always felt that it gives patients the best unbiased evaluation when the different specialties see the patient separately. How about patients who have incomplete workup? You sometimes manage to finagle echo spots the same day. What do you do? How do we do that?
Yeah, so when I do that initial chart review, if I see that their echo was like more than 6 months ago, or if I know that it's coming from a site where, the report is lacking information or the quality just doesn't seem quite there, then I'll schedule them for an echo either before or after their CT scan before they come over to the clinic. But there are sometimes patients that, when we review their images in clinic or there's any question on some of the measurements, we decide that we want to repeat an echo at our site. So we are able to just call over to our non-invasive department and get them added in for an echo as long as they're not too tied down. But most of the time it's not a problem. So then we can just take the patient over to the echo department before they leave. And then we just let the patients know that we'll be in touch after we review those images about next steps. So that works out okay, usually.
Yeah, and I think the other thing that's nice for us is that everything is in relatively close proximity. We're not in the same area, but we're within, 3 minutes walk to the cath lab, 3 minutes walk to the OR, 3 minutes walk to the CAT scanner, 3 minutes walk to the echo department. So we're pretty flexible in terms of adding people on and uh, moving them around in order to get all the testing and necessary and all the evaluation necessary in a single visit rather than multiple visits. Um, how about, do you mind outlining kind of what happens with the patients between the moment that we've seen them in clinic, we either have agreement with or with surgery, what we're going to do, if we're going to do a TAVR, what happens to the people where things may be more complex and we don't necessarily have agreement or we feel that there's a need for more discussion?
Yeah, so of course there's those complex patients where we feel like warrants further discussion with the whole team. So those patients, so we have a weekly valve conference. It's on our implant day. We do it first thing in the morning on Wednesdays, and most of our team is really good about being present. So we have our cardiologists, at least one or two surgeons in that meeting. Typically, anesthesia is often there. There's always echo guys, some nursing staff, and so we will review these cases in question and just kind of bounce thoughts off each other to make sure that we're giving a recommendation that everyone feels comfortable with. So we can review all their imaging together with the team. I usually would, give the patient history so everyone knows the story, and then from there we can come up with a plan, like I said, that everyone agrees upon, and then I would just reach back out to that patient about what our team recommendation is, and then what the next steps would be moving forward for procedure planning, or if there's further testing that we would want. But yeah, it's just a nice way to, of course, there are these complex patients that we can't give an upfront answer in right away in clinic. So we have this opportunity to discuss with all the smart folks and come up with a plan.
Yeah, and I think that that's very useful. I think that keeps us from ever being in a situation where we have, fights, big disagreements. We, if the patients are clear cut, we have a decision made at the time of valve clinic, and I would say that's probably 90+% of our patients. If the patients are not as clear cut, or if there's a disagreement between the cardiologist and the surgeon, we will punt to the time of the next valve conference, which would be within a week, and we have a decision made at the time where we decide on further testing. I think the other thing that you do great, which is the one piece of paper that accompanies essentially every patient and that resides in our virtual drive, which includes all the meaningful information for the patient, and you update on as new information becomes available. And I think we all appreciate that. It's that's the all the information that we generally need in order to dictate our consults. It is also what we bring to the valve conference. It accompanies us in the procedure, and at a glance you can see everything that's going on with the patient. And I know in particular anesthesia is very grateful for that, because we don't have the patients be formally evaluated by anesthesia before their procedure, but the anesthesiologist who's going to be doing cases with us can go 24 hours in advance, look at the patients on the list, see exactly what their pathology is, and if there's concerns, they can always call us up, and that way we agree and we address any issues proactively.
Yeah, we try and really kind of keep an open communication with anesthesia, especially too, and just that face sheet I make it's nothing earth shattering, but I try and keep it concise. And so, like Dr. Pop said, as the patient kind of goes through workup, I can just add to that face sheet, and then we use it on procedure day to review again and just make sure we're not missing anything. So yeah, anesthesia has liked it. I do try and send that a day ahead or a day or two ahead of time before the procedure, just so they kind of know what they're walking into. It's worked out.
And talk to me about pre-procedure testing. So obviously, most of our patients, when they come referred from outside, have had an echo, have had an angiogram. We do encourage the primary referring service to do that because we don't want to steal their thunder and we want to let them do their own. Um, we obviously get the CTA unless they're comfortable getting CTAs, and some places are, most places aren't. Um, what other testing do we get? All the places are getting carotids, they're getting PFTs, they're getting urine analysis. Tell me kind of what testing do we get and when do we get it?
Yeah, so we have kind of gradually done away with the tests that we felt like weren't really contributing to the planning process. So, of course, yes, we have that baseline echo, the CTA. Most patients were still getting a coronary angiogram, unless, they're really kidney insufficient and we can see on CT that their grafts or whatever are open, but for the most part, we're still getting that cath. And those two, the referring physicians, most of them know that we're going to need that. So a lot of times they do it ahead of time before sending the patient over. But we have done away with PFTs and carotid ultrasound for the most part, except in select patients if we feel like that information would help make a safer plan. But for the most part, we, in the early days when we were doing those tests, it didn't really change the plan. We would typically still proceed with TAVR, and since our anesthesia, we've really scaled back on, we're doing MAC now, and not general anesthesia. So, the PFTs really don't contribute a lot of helpful information. And it was just another step, an appointment and scheduling thing for every patient. So it's really helped simplify the process for us, for the patients. So for the most part, we're not doing PFTs or carotid ultrasounds anymore. And then, yeah, in the last year or two, we've stopped doing the pre-op urinalysis, again, based off data that showed that it didn't really impact, valve infection or anything. A lot of these older patients have, colonized urine that we can't do much with anyway. So again, it was just another way to simplify our workup. And we've, it's been good. We haven't had problems without doing these tests. So of course, in the select patients, we do it as needed, but we've been really minimizing, and it's worked out.
How about blood work?
Yeah, so we do standard, pre-op blood work, and we do a type and cross. So most of our patients live relatively close, so we'll just have them come in within 6 days or so of their procedure for that blood work. But for patients that come from a distance, we're able to run a quick type and screen the morning of when they arrive, just so that, again, those far patients aren't making a million trips up this way. So that just helps with patient satisfaction for sure.
Yeah, I think a lot of places around the country see delays with the type and cross, and the fact that we do that in advance when the patients come for their regular blood work, and they actually we know that we're going to have blood ready for them when we do a procedure, makes a big difference. And I cannot remember the last time we had an issue with delays due to blood availability, and we certainly never cancel anybody due to blood availability. Again, due to this process where you have them coming in early and getting everything done ahead of time. So to wrap up, tell us what do you do in follow-up? So our valve clinic not only sees the patients in pre-op, but you also see them post-op. So can you outline that process?
Yep. So I see them usually within a week of discharge here in the clinic, and it's mainly a wellness check. So it's usually a quick visit, but I do a groin check and we do an EKG and just a review of their medications. And then from there, we set up their 1 month visit. Again, this is just a registry requirement that you have that 1 month echo and visit. So I take care of that here in the clinic as well. They'll come and do their echo first and then just come to the valve clinic afterwards so I can lay eyes on them and kind of look at the pictures, do like a prelim eval of that echo and EKG and everything and make sure they're looking okay. We do always send them back to their, referring cardiologist. So I always tell them to continue with their routine visits with cardiology. And for patients that are coming from a distance, we let them do that 1 month, the 1 week and 1 month visit with their referring cardiologist. And those physicians know the routine and know what we're looking for at that 1 month visit. So they're good about just sending us the records so that we can scan them into our system for registry review. So,
And they do get a next day check-in as well, right?
oh yeah, after discharge, we are calling patients to check in. We do just kind of a symptom review. Some patients will try and do a video call, but this population, a lot of times it just doesn't work out. So, but we always are, our clinic nurses calling them to check in and review their appointments and, make sure that they're doing okay.
Good. Well, Lynn, thank you very much. I hope this is useful to the murmur community. I will post an image of our kind of face sheet that includes all the useful information, which I think is one of the hidden tools of our program. And if anybody has any questions, feel free to send them in. And again, Lynn, thank you for doing this, and thank you for everything that you do for the program.
Yeah, no problem. Thanks for having me. I hope it's helpful, especially to all the coordinators out there. It's a tough balance. So yes, glad to
We
help.
we couldn't do it without you, you know that. So
Ah, thanks.
thank you so much.